So this webinar is brought to you by the Body Doctor. I'll be sort of the co-host today. Bring it to you. My name's Alex, and I'm the key account manager at the Body Doctor. So just before I introduce our very special guest, there's a few housekeeping bits that I just need to go through with you guys before we get started. So first of all, the session should be anywhere between 1.5 hours to 2 hours, depending on questions, interactions. It can vary, but we're looking at about that there. So another thing, this session is recorded, so the whole session is on record there. And like I've mentioned before, for the new people joining, any sort of questions or things you want to ask Laura, you can put it in the little chat box in the corner there. So you'll see it in the bottom right of your screen. You can pop any questions down and I'll be noting them down and asking Laura when it's an appropriate time. We haven't really specifically decided when we're gonna, take breaks and stuff, but we'll see how it goes in that case. If any questions
I think we should time blinking breaks, because probably everyone's worked all day, and then we're going to talk about this concept of remembering to blink. And I feel like we should actually be doing that today. So maybe Alex, every 10-15 minutes, remind everyone to blink and then just have a check.
Yeah. I'll come on with the eye drops, and get them there. So in terms of any questions that are missed, obviously there's a lot of people attending today, so it will be hard to answer everyone's questions, but if you're urging to get an answer to them, you can actually email the marketing email. I'll put that in the chat right now, and I'll put it in the end also, but it is just marketing@the-body-doctor.com. And then at the end of the webinar, you'll get instructions by email automatically from WebEx on how to, claim your CPD points. If that doesn't work, you can also use the QR code that will be at the end of the slide, I believe. So tonight's session, it's on what's driving dry eye, breaking the inflammatory cycle. There you go.
I'm going to break that down.
Yes, so very interesting topic. In terms of our real host today, our special guest, we've got Laura Maubon. Laura is a consultant ophthalmologist who specializes in anterior segment surgery, ocular surface disease, and surgical education. She works as a locum at Moorfields Eye Hospital and recently completed surgical education studies at Imperial College of London. Tonight's lecture will explore ingredients of the tear film, understanding the ocular microbiome, and the modern causes of dry eye. Wow, very in-depth, Laura. So,
I mean, if we've got an hour, it should be, but I'm worried I'm going to forget to tell you guys something that you might. So just if there's something, please remind me, because it is an evening, and we're primed to be brightest in the morning. But I'll do my best to make sure that you can absorb as much as possible of an evening. So from an educational point of view, we'd always be like, take many breaks, just set like a couple of objectives, and like don't try to absorb it all, because it's going to be very, very challenging to do all of that this time of night, I would think. But hopefully you'll get some good pointers.
Okay,
well, everybody got their sound sorted. A few people are saying they've got sound problems, they can't hear. Is there anyone with that? Claire and Sasha. Okay, Sasha's is working, Claire's not sure. It might be that you have to accept the sound. So if you're on like my phone, for example, or a iPad, when you go into it, it does say like, can the device access the microphone? So it might be that. So just, you might want to log in, log back out. All right, I'll share my screen again.
Okay, so I will leave it to you now, Laura.
Okay, lovely.
I'll turn off the video and mute myself, but if you need me to jump in at any time, just give us a shout. And like I
Okay,
say, any questions I'll be noting down from the chat box.
lovely.
Okay, bye for now.
So, good evening, everyone. It's a real pleasure to be able to share the evening with you. So, I hope that you all get something out of it and I don't bore you to tears, and make sure we finish in time so that you can enjoy the rest of your evening, whatever you want to do. So, why I'm really passionate about the dry eyes, I actually think, before I begin, it's about thinking about it a little bit differently. And why is everyone so interested in it? Because it's so nuanced, and it has like all these variations and complexities to it. And we're starting to realize that that whole ocular surface system itself, for your tears and the interplay of the surface of the eyes, that's kind of the cornea, the conjunctiva, the tarsal conjunctiva, which is in the inner layer here, and the lid margins and adnexa. They've all got this relationship, and it's so much more complicated than we ever thought it was, which is why we can't stop talking about it. Um, as Alex introduced me, yes, I work as a local consultant. My background was in sort of cornea and anterior segment surgery, but I found myself becoming more and more passionate about the medical cornea, and especially because when you see the extreme case of dry eye, in terms of a clinical perspective, you see how their whole life is surrounded by putting these drops in their eye, and at the most extreme end you have these sick patients taking 30 to 40 drops a day, and they can manage 2 hours of screen time on their computer to work. Or one of my patients would get up to 4 hours a day, 4 hours a week would be a good working week for her. So it just shows you what disability is if you don't have tears. And then you have the other extreme where you don't have many symptoms, and yet they have so many signs, and they're so debilitated because at some point they've almost become so sensitized at the nerve level under the epithelium. So that's sort of the anterior stromal level where you get damage in the epithelium, and their nerves get so sensitized it becomes this kind of cycle of bombardment on the surface, and it triggers off some kind of neurological response. And so these patients get up with this neuropathic pain that they can't always switch off, even when you've treated the condition. And these patients, in the worst case scenario, can end up suicidal, and we've seen case reports of that as well. So it's not all as simple as we sometimes kind of make out that it is. Here is a QR code that the body doctor has kindly provided so that you can get your CPD, and we always ask for feedback. I actually want to say thanks first of all for Ross, who is a very passionate dry eye specialist as well. Comes from a different background to myself, but we look at things in a kind of holistic and complete way. Also the body doctor Alex and Sam and Emma and the team there who have invited me to participate today and share my story about dry eye. These are some of my affiliations. On an international scale with the European Society, we do a lot of talks about cataract and refractive, and it's particularly important nowadays that we've started to recognise that the surface of your eye has such an impact on the measurements and the quality of the measurements that you would take before you consider doing refractive or cataract surgery. So quite a lot of the talks you'll see given in dry eye is with a view to kind of picking up those signs, symptoms, just to optimize your results. And the way the world is working now, especially in the private sector, people want perfection. So priming that surface is really important. So this is my disclaimer. I really do like talking about dry eye. So we will build in those breaks. We'll build in those screen breaks as well. And then we'll just, maybe every segment, we'll refer back to Alex. I'll stop sharing and give you a chance to chat in the middle. So in terms of the contents, we will talk a little bit about the tear recipe and look at the inflammatory modern world and how that can cause an inflammatory ocular surface. There's this it's not actually new, it's been around sort of a decade at least, but we're starting to learn more about the ocular microbiome and what is that. And then we're going to look more clinically at how we might listen to dry eye, look for dry eye, and then manage the dry eye. And then if we have time and you're interested, I can show you some of the special cases that we manage in ocular surface clinics. So the tear recipe, I always like to think of this as a recipe book. And why is that? That's because if you don't get your recipe right, it won't be the same. So, when you have these special dishes that you get made from people, and you don't have the quite format, the quite constituents or the right ingredients, it never tastes the same. It's just not the same. So the tears are a little bit like this. They've got thousands of different components, and even the structure itself requires a very important homeostasis for them to work well. So the tears have to work really, really hard. You've got these well-recognized 3 layers. So you've got this kind of mucus sticky layer, and they help to stick the tears on. Then the largest layer is that aqueous layer that contains a lot of constituents you can see here, proteins, cytokines, etc. And they also contains vitamins, and they also contain things that protect you. So they are part of that kind of immune system. Then on the top, you have the thinnest layer of the tear film, which is the oils. And the oils, the Maubon, who we talk about, it helps to stop those tears evaporating from the surface. So if you have a reduction in the aqueous part, you then have a higher concentration of the tear, and then that increases the osmolality, that makes them more concentrated, that makes them less functional. Then you may have an imbalance with the mucus, and you might start seeing sticky bits of the mucus, or you might start seeing strand formation. And if you're unlucky, those strands can stick and anchor themselves to the corneal surface, and when you're blinking, they pull, and you see these filaments. It's very uncomfortable. So in your aqueous deficient conditions, you often see increased mucus because they have got less aqueous. So that Sjögren's picture, less aqueous, more stickiness, and those filaments, very uncomfortable. But we often talk mostly about this evaporative dry eye, and that's where the tears are short on the hydration or the aqueous components, because they're evaporating from the tear surface, because you have insufficient oil to stop them from evaporating. That's kind of one of the common things, and the oil comes from the lid margins. So that's this, you know, what came first? Is it meibomian gland disease or the dry eye disease, or is it a bit of both? And that's where we talk about this cycle of inflammation, like chicken and egg. So the oils themselves, I mean, I'm actually just going to let people go on the chat here. How many different oils do you think we have in the tear component? So just have a quick look on the chat. Do we have, you know, just as a guess, do we feel that we've got like 5 different oils, 1 type of oil just in the tears themselves? So we've got 3. 3 is a very popular estimate for the oils in the tear components. Give me another minute. Anyone want to give a range? Maybe, you know, is it in single figures? Are we in double figures? So we've got some bigger ones, 5, 20. So the last time that I looked into this, there were hundreds, if not thousands, of different nuanced types of oil, if you actually break down the different compositions of oil. So it's actually way more than you can imagine. So what does this mean? This means that what nature has synthesized for you is not possible to replicate with artificial tears. So as hard as we try, what nature has given you is a tailor-made, unbelievably nuanced tear, and they are quite remarkable. So when this imbalance occurs, this homeostasis, balance is lost, it really does cause problems. So they have to work so hard. So when I say the tears have to work hard, is they are the precorneal film. And not only are they responsible for keeping the surface, they contribute some of the nutrition as well. But they not only they coat the surface to keep the vision clear. Without them you can't see. They help to bend the light. They bend the light before the cornea. They're helping so with refraction, with vision. They're helping with nutrition. They're helping with immune defense and comfort as well. So they are absolutely incredible. So if you go out onto the train, you go out into the air condition, you go outside, you go out into the hay fever season, how hard are they having to work to clear and resurface the eye constantly? And they create this lubricating pathway as well. So they really are special. And they are approximately about 2 microns to 3 microns in thickness. I don't know, I might have an image later where I might have a Scheimpflug image where I can show you that. So where are we? Any questions? Yeah, and I'll just have a quick look. So if you have questions, pop them on there. I'll keep stopping. So have a little blink. So dry eye in the modern world. We're very lucky. In about 2007, the dues to this collective group of people, they got together and they said, let's try and define what is dry eye, because we're starting to get so many different ideas about what it is. It's actually a multifactorial disease. So it's a multifactorial disease that's contributed by all different environmental, systemic, direct and indirect influences. And the ocular surface is characterized, so the actual disease is characterized as loss of homeostasis. So what they really mean here is the loss of the balance of this system, which is actually easier to do than we thought. It's then we accompany it with the ocular symptoms, but you can have it without ocular symptoms in which the tear film instability and the hyperosmolality, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological role. So that is a huge diagnosis here. That's a huge description. So key to this, to diagnosing dry eye disease, is that tear film instability, hyperosmolality. So when we're talking about that instability, that's that breakup of the tears that you see when you measure the tears, and that's where the oil is insufficient to help with that stabilization, or the recipe is not in balance. The hyperosmolality, that's talking about that higher concentration where maybe you have less aqueous because it's evaporated, or you're aqueous deficient in the first place. So that's almost diagnostic. You don't see dry eye without that hyperosmolality, and it can pick it up in earlier disease as well. Ocular surface inflammation and damage. There are degrees of this, and as you see inflammation damage on the surface, that's how you can enter spiral. So you don't always see a great deal of inflammation damage early on in the condition, but it is the insults that then can trigger more. And then this neurosensory abnormalities, there's this almost hypersensitization that can start to occur. And then those dendritic cells, which are nerve cells, they themselves possess these receptor cells in them, which can then trigger more inflammation. So it becomes this kind of this cycle that we talk about. So this is here basically going through that same concept. So essentially, you have that instability of the tear, you have that imbalance in the tear, which can be caused by an external insult. It can be caused by lack of production, can be caused by increased evaporation. That in itself is enough for the tears to become more hyperosmolar. So that's increased concentration. And then if you don't have those protective features, you end up having cell damage. So where the tears are not protecting the epithelial cells have, again, these antigen presenting cells. And if they have insults, then that will trigger inflammation and cause damage. So in your tear film, you have cytokines and chemokines, and these are all these technical words just describe these cell modulators that help with homeostasis. And in the inflamed environment, or in the environment where you've got unstable tears, you may get an increase in the inflammatory cytokines, for example, and then that will lead to cell damage, and that cell damage can then lead to nerve stimulation. That nerve stimulation can lead to further damage, inflammation, and that can lead to further problems as well. So then you kind of see these consequences. You'll also see the word metalloproteinases, there's MMPs, and you'll see like 3 and 9, and these are upregulated as well. And there are particular inflammatory markers that people can measure. So there are people that have taken the tears in inflamed dry eye, and then they've said, well, these are the markers of dry eye, so like IL-6 and things like this. So they are quite nuanced, but there's a lot of research to really support these inflammatory markers that are present in dry eye disease. So if you have this happening chronically, what might happen? You might start to change the architecture around the eyelids. So you start to see changes. So one of the things that can happen is these goblet cells, and these lovely, I call them like gobble cells to remember them, because they're really important, and they produce this sticky, like goblet, sticky stuff, sticky oily stuff. You want that. But if you don't have them because you've got damage to the cells, you're not going to be producing all these lovely components, which will then feed back into the tear instability. So damage causes damage to the cells. You get architectural damage, you get actual damage and loss of cellular structures, and then you start to get further problems. It perpetuates problematic production so you don't produce the same components for your tears, and you get this perpetuating cycle. So hopefully that makes sense. Do people feel quite happy that kind of makes sense, this sort of spiral effect? I think another way of describing it is not just a cycle, but maybe even a spiral, because you might enter the cycle and then suddenly you might start to spiral. And it's about trying to provide, so you it might be as simple as increasing the aqueous or supporting the tear with that aqueous, those eye drops to begin with, as well as trying to introduce the oils back into circulation by treating the eyelids. It could be as simple as that. But if you've already got into the cycle where you're getting inflammation that started to cause damage, and you start to see that pinkness, that redness, you start to get little change on the surface, that actual inflammation, cell damage, then you may need to start using anti-inflammatory or use a natural anti-inflammatory. And we'll talk a little bit about natural and anti-inflammatories, both systemically and also topically later. So, I mean, everything is changing. The average person is using a device. I think it's 60% of the population, I believe, of the global population is engaging in social media. So does that, I believe that figure actually includes accounting for children as well. And as you know, in the press, there's a lot of sort of benefits to not having access to devices and social media, because they are designed to be addictive. They're very cleverly made. So we are, and I'm addicted. So we are looking at screens on social media, I think 2 hours, 2 to 3 hours a day, just on additional leisure screen use. So if we're doing this leisure screen use, what's actually happening then to our ocular surface? So what is it that's, why do the screens, because they used to say sort of radiation, things like that. In fact, the most evidence suggests that it's actually the blinking. The main thing that's really happening is that we're not blinking. So when we look at screens, we don't tend to blink as well. And then that causes the tear film to break up. And then you may, in effect, trigger yourself into that sort of dry eye cycle at that stage. Alex, do you have any questions that you want to ask? If you've got any, because someone's nearly 11 hours. Is that screen use in a day? Because I guess if you have used screens all day today and you're using screens now, it could be 11. You can easily do 11 hours in a day without your social media. Any questions from your end about things so far?
Yeah, I just had one earlier from Fatima. How does anemia cause dry eye?
Oh, from earlier.
Yeah.
Well, so any kind of systemic conditions, so autoimmune or insufficient problem, like you don't have the same production of protein. So in some forms of anemia, you won't have the same protein production. So then your body might not prioritize having all the ingredients. So I actually would need the exact mechanism I'd have to look up. But if you're insufficient in anything, your body can then not prioritize a lot of the more sort of sparing sort of products. So the tear wouldn't be as high as priorities like the blood, for example. And then like you get hair loss as well in anemia as well, and you get skin changes in anemia as well, because they're a higher turnover cell. So they sort of don't get prioritized, if that makes sense. So the quality or the kind of available proteins are not there to sort of make them as well. So we just see that in conditions like anemia, autoimmune disease, you can be more likely to have ocular surface inflammation as well. But also in anemia, there are different types. But gosh, I'm trying to think exactly. But I believe it is to do with those proteins. But I actually might come back to that, because I feel like it's something the actual mechanism I'd need to sort of brush up on. But it's the same with the skin and the hair affected in anemia as well. But I think it is to do with protein and availability of resources in the body. Alex, do you use screens?
Of course, yes.
Do you use screens more than 2.5 hours a day?
Absolutely.
What about just for social media?
Yeah, plenty on there.
Yeah, so someone's saying they've observed traveling on train or tube, people they're blinking every 3 or 4 minutes. Yeah, the blink rate, it really is incredible how that people just forget to blink. So that in itself could trigger you into sort of a dry eye pathway. And we are seeing young people, and we traditionally saw dry eye in older people, women who were going through hormonal changes, menopausal women, postmenopausal women, people going through surgery, age, because the quality of the tears is different as you get older. But now we're seeing that in working age people, especially working from home, there are quite a few studies done around COVID where we switched to being online, and they were basically suggesting that healthy working age adjusted populations, it could be between 10 or even 70% in some groups were experiencing symptoms of dry eye. So if they're experiencing symptoms of dry eye at this stage without clear cause, and it could be a lot of it could be related to the screen use. So what else are we doing in our modern world to upset our tears? So apart from all the screen time, it's also our individual factors, our working conditions have changed as well. So we're living in like more concentrated populations. We're working indoors a lot more than we used to. So we have like less circulation of the air, and you can be more likely to be exposed to heating, and air conditioning can also be a problem as well. So all of these nuances can have a role in which they can upset what nature gave you, essentially. One of the big ones that doesn't get talked about, I don't think, near enough, is makeup. And why is makeup so taboo? Because especially in my field, if you look at the cornean specialists in medicine, for a long time, it has been disproportionately men. And I don't know whether the conversation comes up as easily to say to your patient, who is often in dry eye disease, female, that they shouldn't wear their makeup. Now, I'm not a strong believer in saying to patients, don't wear your makeup. I believe in saying to patients, why don't you try a makeup free trial or no mascara trial, or look at, you can get your lashes tinted or have a makeup holiday and see how your symptoms are. Patients really need to know for themselves what the benefit or problem is with their makeup. One of the products that is very popular is retinol. So retinol is like a vitamin A derivative, and people love to put that on. It's good for wrinkles, skin, acne, and yes. So someone's actually saying always advocating safe use of makeup and skincare has made a huge. It absolutely does. So the fact is, on our skin, it's very hard to avoid things leaching into the tear film, but retinol in particular does have a drying effect on the ocular surface. Really good for the skin, but we don't want that in our eye. There are different mascaras, which some of them say that they're better and they're less irritant. I think waterproof mascara is quite challenging to actually get off, so that can be problematic, but at the same time might not flake. So patients may need to experiment with what they have. So as I said, I think it's very difficult to say to your patient, stop makeup when they really love their makeup, but modifying the way they use makeup can be really helpful. I sometimes tell patients to use a little barrier, especially if they're heavy powdery foundation users, because the foundation particles can get into the tear film, and then you can, I'm sure many of you've seen it, that kind of beautiful iridescence, that glow, and you're like, oh, they've got this lovely glow from their foundation or from their eyeshadow. So you can really see that in the tear film. So I would say, like, if you can sometimes just tell them to put like a little Vaseline or a barrier and just clear it to try and stop those powders going in. Cream products I advocate sometimes. So I've got a patient who's been told, no, can't wear makeup ever again, but she has a very poor ocular surface, transplant surgery, and so she hasn't got a lot of defense. She doesn't have the tears to defend herself from potential insults. So in her case, I still said, if you use a little bit of barrier, use some cream, just to make her feel a bit better, but avoid the powders, avoid the mascaras. But there are things that patients can do to make themselves feel better, and to use it occasionally for like a special event. So let's have a look. So mascaras, false, yeah. Subhash, I think you don't, yeah, you're not liking the mascaras and the false eyelashes. False eyelashes, I mean, there are some incredible ones, to be honest, but it's very difficult telling a patient don't use them, because that's the root of all your problems. So I've got Ross saying, makeup, I never stop, but I too am experimenting. Yeah, I do think it is about experimenting. So I actually am wearing mascara tonight for you all, but again, I don't wear mascara for my operating list. I don't put it on for long days at work. I tend to prioritize it for when I might do something like a family event, a party, or if I'm going to have to be on a camera, because it does make me look more awake. So if I was told I could never wear mascara again, that would be a problem for me. But at the same time, I can directly link having irritation to mascara. So then it's all about making sure they take that off and do that thoroughly. So you often find, so I'm still banging on about makeup. I'll do a little bit more about makeup, but so when they remove that makeup, they often don't get it all off. So this could be they use, oh, but I use a makeup remover. So the makeup remover is not actually cleansing it off. So I actually quite like it when they use, so there's lightly foaming products, so you can get those blepharoclean, you can get little foaming, I like foaming products which help to really break down and clean. And I also think the sort of the wipes, the blepharitis wipes, they're also really good at cleaning, and they're quite generous in their size. And most of those ones are really good at getting a good clean as well. But yes, makeup breaks. How is it when you go on holiday? Things like that. The facial bleaching creams is really important here, because we've actually seen patients where that's leached into the ocular surface and it's actually caused limbal stem cell damage because it is toxic. So recurrent insults, if you break through those tears and you actually get to the surface cells and they're chemical and they're toxic, you can actually get chemical injuries from these things. And there are case reports again of people from their product causing themselves chemical injuries, and then those stem cells, they don't regenerate, then they get clouding of the cornea, and they also get ocular surface irritation as well. So it's a big one. It's a really big one. So we're having a look at we've got false eyelash, hypochlorous. So hypochlorous is one of the products. It's the spray one. So this one is very good. That's interesting. False eyelashes are my pet peeve. It's quite interesting reading the tips. So a lot of people are getting a lot of eyelash. Okay, some people so yeah, there's a lot of discussion here about eyelashes. The reality is if your patients really feel the need to wear these things, it's very difficult to not treat the whole patient. And we really do need to think about the whole patient here, because if you've got somebody that's got dry but they can't ever feel comfortable in their own skin, and you don't give them the good advice about makeup and things like that, then you're setting them up to go and do things which may be less safe. So wherever possible, you can try and practice good makeup practices, good makeup removal, and have those kind of open discussions and educate your patient, and then you've got the best shot. Doing all this in a short clinic is quite challenging. So there's a lot, really. Okay, so I think we've had quite a good chat about makeup. I'm happy to anything that I'll just take a quick blink break before we go on to the microscopic stuff. Anybody want to share now? Or I feel like we've made ourselves up, I'm just joking with myself because I'm alone here. Okay, so I feel like we've done that's quite a lot. So I think the responsibility of what we do to our bodies is quite relevant here. So I'm going to carry on. So this microscopic concept, we're going to have a look here. On a more kind of global scale, so we're going to go back outside of the eye right now and look at what's happening environmentally. So I know that Donald Trump doesn't agree with us or me or a lot of people actually, and he's withdrawn from a lot of agreements last night. But there are a lot of people that say these are biomes and are microbiomes. So these are naturally occurring communities of flora and fauna, which they occupy a major habitat. So the biomes are big. So this is like forest, tundra, ocean, these types of things. Now we have little microbiomes all over. So even within our body, we have very sort of specialist areas of our body that have their own community of microbes and microbiota and things like that. So the ocular surface itself, the lids and the ocular surface, they have their own collection. And this is why and it's a living, breathing part of the ocular surface. So it's an ocular surface system in which we have our tears as well. And it's actually a lot more important than we ever sort of realized, or certainly I hadn't realized. And I'm sure unless you've started thinking about it, we don't realize it. But if we think globally on a big scale, we know that when we upset part of those communities, those natural communities, we have a cause and effect. We know there are natural cycles, but we know that if you alter alter a biome, and you take away something, or you destroy something, or you add toxicity into that environment, you change that whole balance, you change the homeostasis, and that is quite similar to what you might see in the ocular microbiome. So we know that there is actually a gut ocular link. So we often think about microbiomes as gut. They're these small bacterial overgrowth and how it affects us. So we're starting to really understand from a gut level, but there's even a gut ocular microbiome link as well. So people might have a problem in the gut, and then they would also have problems in their eye. So there are a few reports. Have I got them all? I think they might have time. Yeah, but there's quite a few. These are some of the very good ones. This one in particular is it's quite a long read, and it's a little bit heavy to begin with, but it is quite informative. I'm just going to see what I've got here. Yeah. So in terms of the ocular microbiome, the colonization does begin at birth, and quite quickly you might be thinking, oh, is it vaginal delivery or C-section? So for those of us that maybe had a C-section and you feel guilty, you don't feel too guilty, because by about day 3, the baby's ocular surface does tend to catch up. You also find that there is a increased colonization of different commensals as you get with age. So I think I need to clarify this a little bit, because I haven't gone into too much detail. But basically, the microbiome and the microbiota, they are consisted of bacterias and viruses and parasites and all sorts that live on us naturally. So if you even take a healthy tear film, you can even sometimes find a canthamoeba that exists in that tear film, but it is not causing a harm. So if you looked at lots of tear films and ocular surface systems, you will see bacteria in them, but they live there, not causing harm. So when you have an imbalance or a problematic tear, you cannot protect yourself, or you cannot live harmoniously with these important commensals. So let's take Staph aureus, for example, and I'll come back to it. Staph aureus lives on the skin, and it's often seen in marginal keratitis and meibomian sort of chalazions in inflammation there. What you'll see is this exists, and it exists as a commensal, and the commensal, it lives harmlessly. Now, we need the commensals. We need them because whilst they're present, they act as rivals to prevent other more pathogenic, so more likely bacteria to become pathogenic and cause disease. They protect us from that. So whilst we have an amount of species in our system, if we have a healthy system, we will have species, and they will literally defend us from having other species. So when you have a breakdown in the system where you don't have enough protection, those commensals, those harmless bacterial organisms, they will then become pathogenic because they become opportunistic infections. So it's recognizing that there's an amount which is normal. So you will see viruses normally. So that in itself is not a problem. So what you're expecting to see is, as we age, because you come across new things in the same way that, let's think about a child goes to nursery and they get all these infections, and as they get older they get less and less infections, but because they're exposed to all these viruses, bacteria, and they build an immunity. So the tears, once again, come back to that kind of that almost like an immunological system itself. So you get exposed to all these things, and as we get exposed to these things, you'll see a diversity. So you get a bigger range of different commensals and things living on the ocular surface, and as we age, you see more. So what we also see is that in different countries, different climates, you'll see different ones. In fact, to the extent that in one study in China, people went on holiday for 2 weeks and their microbiome changed, their ocular microbiome changed. So it really is, it does differ. It almost makes you think that if you go to a different environment, your body is automatically trying to adapt to help you to kind of, build up your immunity there. So it differs and it increases with different population, different disease. So something like diabetes, there is some evidence that shows that when diabetics have higher glucose concentrations and poorer control, their microbiome changes as well. So there is this suggestion that pretty much the way that our systemic body is will affect the way our ocular surface behaves, because it's part of almost an immune system itself, and then that will affect our tears and risk of dry eye. There are gender differences as well, and it's not quite as marked as you'd necessarily expect. So what is normal? This is probably a little bit in depth, but these are some of the microbiome and sort of the names that you might come across. So here you can see in West Africa, US, Australia and China, there's a few familiar ones. So in this Cornybacterium features in all of them, but in China. And the Proteobacterium features in all of them, but not in Australia. So you can see there's some regional differences. So what is a normal microbiome is not clear exactly what normal will be dependent on your environment, dependent on your age and all those types of things. But Staphylococcus, you generally see features in staph and streps are very, very common. There were some studies that showed that the Proteobacterium was less present in dry eye disease. So that actually is something that's quite important as well, to have that. So that diversity of species is actually important. Okay. So when you get exposed to these different sort of microbiota or commensals, it's the interaction with the antigen presenting cells that were present in the epithelium. It depends on the response, how they respond to them. So in a healthy ocular surface system, your eye will come across these antigens from these microbiota, and it will sense them. It will send out a T effector cell, and it will say, okay, don't worry about this. We're not going to get excited about this. And when it comes again, it recognizes that, okay, we're not going to worry about this. We're not going to set off inflammation. When you have a dysregulated system, those antigens will arrive, and then the system will be like, okay, this doesn't look good. Let's trigger a cycle in which they would then cause inflammation to be released instead. So then you get these cytokine upregulations. So these into the IL-6s, so the cytokines that you see before the MMPs, they become upregulated, and then you get inflammation on the surface. So this is very similar to allergens like hay fever and things like that. When you have the wrong response, the body is actually responding in a way that you don't want it to. So if your tear film or your tear structure is not perfect, you're more likely to have these issues. So in the images on the left-hand side of the screen, you can actually see that there is, I think you can see sort of some whitish areas here. There's sort of a marginal keratitis, and this is likely to be probably like a staph overgrowth here. And in the top one, you can see some vascularization. And in particular, you might see in children, they get quite good going, sort of flicked in these very large responses, because their inflammatory response is so much greater. They have a very sort of, you can really see quite large changes, in particular like staph. So I do remember one patient coming in, and they had almost like a 1 millimeter elevated lesion. I thought, oh my goodness, how am I going to treat this? And they had like lots of blepharitis. Literally giving them chloramphenicol, it went down within like a week, and they had steroids as well. But it was unbelievable to see this physical sort of lump go sort of settle in real time. And you also have the lymphatic system as well, so they can become very enlarged very quickly, especially in children, and especially in young children. And that's a whole different talk, but certainly in allergies in young children, prepubescent boys, classically, they can have these very, the lymphatic system can be very upregulated, and they get these really large responses. So what's sort of disrupting these systems? Before I go into that, would long-term use of prostaglandin, we've got a question here. Would long-term use of prostaglandin drop medication, preservative-free, have an effect on the ocular surface, as I see a fair amount of inflammatory response and dry eyes in these patients? So, Subhash, there's actually a paper in the Eye, and I believe it came out this month. So if you go on the Eye, and it was a cross-section study that looks at that, the prostaglandin, use of prostaglandins. And I think prostaglandins, it's not really strong evidence, but there is a suggestion that they would be harmful in the long term use. So that's, again, that's a glaucoma drop, those the prostaglandin drops. But yes, you will see the quite good evidence, or some evidence. But yeah, it's actually this month, and it's just that it's still inconclusive, because the way that the data was pulled in each of the studies, it was different. So the way the data was looking at prostaglandins and ocular surfaces, everyone is a little bit different. So that comes round to, is it that conclusive? But there's still a suggestion that prostaglandins are inflammatory, and that inflammation can then contribute to dry eye disease, even preservative free. So this kind of macro and micro disruptors, so I call them disruptors because they're disrupting this lovely system that you've created, that the body's created for itself. And they come in many different forms. So viruses, medication is really interesting, because so many medications, so actually this literally almost comes onto Subhash has just talked about the prostaglandins, that's topical medication, but systemic medications affect your tears. So sertraline, antidepressant medications, they can all cause problems with your ocular surface. So it is worth thinking about. Contraceptives, so oral contraceptives, anything that can alter the hormones. Again, progesterone is inflammatory as well, so these things can have an impact. Surgery, refractive surgery, cataract surgery, then we talked about that kind of the makeup and the pigments, contact lens use, they're all disruptors basically. Right, so we've finished the kind of the appreciation of the tears. So I feel like we've now appreciated that they are very nuanced, and we've talked about the fact that the environment, both on a kind of macroscopic environmental scale, can affect us, but that impact can have a small scale impact as well. We've talked a little bit about the way our tears have so many different natural components, and the way that what we do influences how the tears behave. So I think we'll just have like a 1 to 2 minute break, so I can answer some questions, but people can catch up before we go on to some of the kind of looking for clinical signs, which probably is quite short, about 10 minutes, and then we'll talk a bit more about treatments. Alex, any questions that you want, or should we just have like a 1 minute break for people? I'm going to do a 1 minute break.
I do have one actually.
Try and answer it. I'm going to look up the anemia question as well.
Yeah, so increasing screen use at schools,
Yeah.
does that ultimately, result in more dry eye problems in earlier life?
So actually, I was literally thinking about this today. It's not been studied yet, but surely that's training us at a younger age to have these behaviors that we're not well adapted for. So I wouldn't be surprised if we see again, this epidemic of dry eye, which we're seeing. It's good for clinicians and privately, but it's not good in terms of population, because devices are not the same as being in the fresh air, looking outside, looking at a board. There is an impact. And I guess the other thing that people are probably very aware about is this shift in myopia. So there's in real time, there are two things. Humans are getting bigger, eyeballs are getting longer, we're getting an increase of short-sightedness, but we're also getting increased short-sightedness from the way that we also behave and the way that our life is all close up now. So this is bad because, you know, if we're getting bigger eyeballs, it's thinning the retinas, it's making the whole system, the ocular, the actual eye system, more vulnerable to retinal tears and damage and all sorts of things, earlier cataract, everything. So the myopia itself isn't ideal, but then the management of the myopia is the glasses and contact lenses, and that in itself means that we're then having more problems with the, you know, ocular surface of children using contact lenses from a younger age. Yeah, so it's tricky. So I'm just having a look at the.
Yeah, I was reading up on Japan,
Yeah.
and how I think it's something crazy like 95% of children under the age of 16 or something like that, you know, were affected in some ways by, you know, myopia and some form of
Yeah, I
short-sightedness.
think Singapore as well, and
Yeah,
China,
well,
and
obviously due to the increased time on the screen, maybe, but
well, it's not just it is partly that, part of it's genetics, part of it's that, part of it's our behaviors. So
okay.
this is a bit of a tangent, but from, I think Prof Hammond in St Thomas's does a lot of work on this, and essentially, my take home message is UV light is one thing that helps. So outdoor light any
Yeah.
time of year is the one thing that seems to slow down the rate. So you have to kick your kids outdoors for 2 hours to 3 hours a day and just get them outside trying to look into the distance. That was the only thing that you could really do.
Mm.
Um, but you know, we adapt to what our behavior is. So if you find that people read more, they become more short-sighted as well. So even historically, before screens, people that were studying a lot, they were becoming more short-sighted. Um, there's something, I'm just looking a bit about the anemia. I'm trying to understand exactly how it does it, because this is something that we do quote it and we don't actually fully, we don't always fully explain it. And now I'm thinking, I don't think I ever really think about it.
I do have another question. Sorry, you're just looking up the
Yeah, yeah,
anemia.
yeah. No, it's talking about the hemoglobin circulating in the environment, blah, 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 saying that it can actually impact on the retinal, because the retina itself has like a very strong blood supply, so it can actually cause problems for the retina. Makes sense, but we haven't really explained it. We're saying it can cause dry eye, but we haven't said why. Yeah, so actually, I think it's something I'd have to, for the actual biochemistry, I'd have to really look into it to understand it. We just know that it. Sorry, so yeah, so what was your question, Alex? And now before I.
Sorry, yeah. The other question was people suffering from, you know, a form of hemorrhage, what drop would we use to help reduce their dry eye symptoms?
So is this a kind of ocular surface hemorrhage, like a
I
subconjunctival
presume
hemorrhage?
so. I might have missed off a bit of the question. I'll just go back up to it. Yeah, so if someone comes in having suffered a hemorrhage, what drops could we suggest to help reduce their dry eye symptoms?
So I never recommend a non-preservative. So I always recommend preservative-free. So I always recommend a non-preserved eye drop for starters, and ideally one that has less excipients. So one that's like a cleaner so even with preservative-free medication, if you look at the ingredients, some have got cleaner ingredients and less excipients. So lubricants that are high quality help reduce the friction, because what's often happening in these hemorrhage eyes is they have some kind of fragility. They might have a little like a little sort of blood vessel that's burst, and usually it's not small. It's usually quite small and quite smooth, and it's not sort of bulging out the eye unless they have a very bad trauma. And it will go up to the corneal edge, and you'll see to the limbus, and you'll be able to pull the lid either down, up to the side, and you'll be able to see beyond the hemorrhage. That's how you know it's a sort of localized subconjunctival hemorrhage and doesn't need to see a doctor. So it essentially is a bruise, and what you want is to reduce the kind of friction there. So essentially any kind of lubricant is quite helpful, because every time you're blinking, you're causing some kind of friction. So that's quite helpful. If it's really bad, so sometimes when you have a subconjunctival hemorrhage, it's really bad, or trauma, without kind of injury deeper levels, sometimes we then give a bit of steroid, because that can speed up and help. But in reality, any high quality preservative-free lubricant will just help to try and reduce the chafing, because it is like just pressing on like a potentially reigniting that little surface bleed. The other thing to note is just check their blood pressure, because they are associated with blood pressure rises, and then there's also association with blood thinning and coughing and straining. So they generally get better on their own, but some can take 7 to 10 days and they go yellowy and they're not very nice. It's mainly about reassurance. But once you have one with these elderly patients, they can end up having more vitamin K. Yeah, I mean, you could if they kept on having them, it might be worth checking vitamin K and those types of things. But I would think just one, and a small one. I think in a lifetime, I'd expect most of us to have a little one. You rub the eye too hard and get little ones. I've certainly had a couple of little subconjunctival hemorrhages, one from sports and then one from rubbing the eye. But once you have one, it's like anything, the area is not perfect anymore, and so it's more vulnerable to another. Just going to finish these questions, actually. I've got another one here. So blepharitis flare, someone's blepharitis flares up when they're on holiday, especially in a dry, hot climate. Yeah, I mean, it could be to do with microbiome, but it could also be in the heat. There is going to be a change in the vascularity, in the way that your skin behaves. It's going to be expanding, and the vessels are going to rise to the surface. So you might find that also in those hot, drier climates, you might have more evaporation of your tears. So you might actually find you're actually having a dry eye from aqueous deficiency, or you might also find that it's your meibomian glands and not doing their job as well. So yeah, you probably find, like, you do find that in like dusty, hotter countries, you get a lot more dry eye allergies. So you go for Turkey, for example. My husband is Turkish, and I was chatting to a woman called Başak Bostani. So she's an ophthalmologist in Istanbul. Every other person has like an allergy or a dry eye symptom, and it's because they have such a lot of allergens and pollution and congestion in the cities there, and also the heat as well. That combination. Does prednisone cause dry eye? I have a patient developed. Well, that's interesting. I wouldn't think that prednisone should cause dry eye, because if it's the steroids themselves suppress inflammation, but depending on whether it was a preserved prednisolone, it might have done. It might be one of the other ingredients that might have contributed towards that. And so Ross saying about the anemia, the aqueous filtered from blood plasma. Yeah, I mean that's right. So I mean we use blood serum to put, because it has all these lovely proteins and things in it, and it has these components in it that we take these plasma eye drops. So if you're anemic, going back to the anemia thing, that if you don't have all those kind of the full complement of proteins and things like that, you probably would have a poorer quality circulating aqueous is possible, I actually don't know. So I think it's like I need to understand fully because it's quite interesting. I'm going to carry on in the interesting time. So listening for dry eye. Why do I say listening? I say this because the patient will walk in and they'll pretty much tell you what kind of dry eye they've got. If you sit there and they'll tell you like they've got itchy, achy, like tired eyes, and you're like, okay, tell me about your job. Within about a couple of minutes, we can do this thing called like conscious listening. So as a chatterbox, I actually do this. I actually sometimes put a timer on, like not so explicitly, but to remind myself just to listen consciously to the patient. And when you allow them to talk, they often tell you that, you know, it gets worse doing this and blah, 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 blah. So they will often tell you what they're doing, whether it's wearing contact lenses or their lifestyle or their job. And they actually kind of give you the information and you can start working out what their type of dry eye is and what their problem is. You can ask about their sleep. So dry eye patients tend to have poorer sleep. In fact, of all of the eye conditions, that's glaucoma, retinal problems, cataract, everything, the ones with the poorest sleep were the dry eye patients. So your dry eye patients are problematic patients in in a good way, because you have things that you can work on or identify. They're like really interesting puzzles. So I don't they take time, unfortunately, but they are interesting, and when you can sometimes help them, it's quite satisfying breaking it down and saying, okay, so when you ask your questions, you can start with these triage questions, and that will help you subtype, first of all, into evaporative, which is about 90-95% of cases, or aqueous deficient. And of the aqueous deficient types, that means they're not producing the aqueous. That often is more likely to be associated with a systemic problem, and those most commonly are patients with Sjögren's or lupus type autoimmune conditions. And then there are other kind of conditions, so graft versus host disease or things like that, so more rare things. But the majority of the time you're dealing with evaporative dry eye, and that will be on a scale of mild to moderate to severe to just, you know, and beyond. And severe can range depending on symptoms as well. So patients might describe that the vision is blurry. Often it isn't consistently blurry. It comes and goes. It might be worse in the morning. It might be that when the tear film is distributing across the surface, it's varying. Gritty, sandy, itchy, rubbing. Sometimes, oh, smeary. That's a nice word. Smeary. Yeah. I like that. I have not heard the word smeary in a long time. Smeary, yes. So yes, smeary. But also like red and just not comfortable. Itchy, sometimes it's not allergy, sometimes it is dry eye. But the red, the pink, the kind of puffiness of the lids, that's kind of coming back to your sort of blepharitis. And what is it? Blepharitis, meibomian gland, or is it ocular surface, that kind of thing. So you can, and I would encourage to do these types of questionnaires, especially if you're working in the private sector, and you want something to come back to see if the patient is kind of improving, or to kind of grade them. So the OSDI, ocular surface disease index, has shown it is used for a lot of research, and you'll see that I think even in the microbiome studies they use that. And so the patients that had, you know, worse like diversity of species, they actually also had like higher OSDI scores and stuff like that. And so they actually were able to correlate some of the scores to different conditions and things like that. So that it's very useful to try and help you measure something which is pretty subjective, but it will still be individualized to those patients. So you're almost taking that individual score and like then using that to help you monitor. And that's a free sort of way of downloading these forms and doing that. And they can do that before they come and see you, and then you can just look at the score. So they don't have to do that in your time in the office. So I think that's always a good thing to do if you're setting up a dry eye practice. So we're looking at the history here. So we've talked about, you know, like illnesses, viruses, medications, particularly hormonal and antidepressants, antihistamine as well, I think can although antihistamine, there is always this one where you sometimes worry, there's in your exams they'll talk about the textbook of like really rare things, like one antihistamine that can cause pupillary, it can cause sort of rotation of the ciliary body and can put you into pseudo block of the eye. But I would say, generally speaking, for eyes, the main drugs that we worry about in dry eye, you're looking at your antidepressants and you're looking at your hormonal treatments. They're the big common ones. When you're talking about your cataract history, we're looking at kind of tamsulosin and also alpha blockers, doxazosin, which we do like to know about as well. And then there's the blood thinners when you're preparing for surgery. They're the big ones. But yeah, there are many. I mean, even Viagra has been shown to alter the way that the iris behaves during surgery. So you could, it goes on and on if you look for stuff. Oh yeah, someone said light sensitivity for a symptom of dry eye. Yeah, light sensitivity because they haven't got those barriers. So that's correct. So yeah, history of surgery, and then I put caffeine on there. So this is the problem. Caffeine and alcohol, all of these things can contribute to dehydration. And caffeine itself has been shown to contribute to ocular surface and dry eye. It is useful to find out about their diet. This is also really helpful to understand. So we're talking a bit about kind of iron deficiency anemia, but also vegan, some patients who are vegan, they actually have got worse dry eye disease, and then you might encourage them to take a dietary supplement. And you have to also be aware that when you're prescribing like omega-3 supplements, you can have vegan and vegetarian alternatives that are important for many patients who want to follow strict diets. But diet is so important. It's important to have a diverse diet. And we know, like with the microbiome, they say something like, I think it's 20-25 species a week. So what that means is in your diet, if you have lots of different species, it helps your body. So even one meal, if you can have 10 species in one meal because you can have in multiple herbs. So if you put in like coriander, parsley, mint in a salad with like spinach and broccoli and avocado with some almond nuts sprinkled on there, and then a bit of lemon, you're already increasing the diversity of the species in that group in one salad. So the more different things you put into your gut, that seems to also be linked to gut health, but also ocular health. That's what we're starting to see. So it is just quite interesting. So optimizing the diet and finding out about that. Yeah, so flaxseed, we'll talk a little bit about dietary supplements later on, but we might as well mention it now. So when you are advising the patient to optimize their diet with supplements, we often talk about flaxseed and omega-3. I actually think all the vitamins, so vitamin D and C, well, we know that C helps with healing, and we know that D particularly helps in kind of rheumatological conditions, especially with collagen and stuff like that as well, and absorption. So making sure you've got a good diet and the vitamins across the board is important. But omega-3 and 6 is particularly been focused on, as well as flaxseed. Now, there's some good podcasts out there that would literally talk about, do you give your patient omega-3? Do you give them flaxseed? That type of thing. If you have got a patient with very dry eye and you don't want to be putting loads of like steroid and product in the eye, then I actually do think it's worth using supplementing with these products. But the studies where omega-3 was shown to be beneficial was a very high amount. So it was a very high amount that they were using. And then that was where they saw it better than placebo. So if you're going to do it, they need to be doing it into a high amount in order to really optimize the absorption of that. Oh, wow. So there's some really interesting ones here. Pomegranate seed, gut parasites, oregano oil. Yeah, to be honest, what you'll find is with the holistic side, there isn't any really good consistent evidence. But if you have a patient that's open to it and they don't want to take sort of medicated, lots of medication, I do advocate having that open discussion about what could exist. But as a doctor, I always have to be a bit careful about what hasn't got any literature there. But certainly, I think from in a private sector, you can present these ideas to patients and they can then research them for themselves. So when we've listened for dry eye, now we're going to look. So these are some of the classic things. So we've got that collarette in that blepharitis. So these lovely kind of flaky bits of skin. They look nice, but I think they look quite nice to look at. It's quite satisfying when you see them because you can then tell the patient, you can photograph it, you can show them. So then on the top right here, you've got some lovely chunky oils. So this is meibomian gland disease in real time here, and you can see that they've got that creamy, thick, buttery consistency, but they look like they're expressible, and that's important because you want to be able to allow them to go away and do treatment where you can heat them up and then you can express them, which helps to break them down. So in what you want is to kind of go almost from like thick butter and turn it back into a really refined, sort of like a rapeseed oil appearance, like a virgin olive oil appearance is also okay. So I kind of think of them in everything comes back to food, doesn't it? All the recipes. So this is so almost like a lovely, you want to get them to that nice sort of virgin oils. That's where you want to get them to. And it may not actually be possible for every patient to clear this mechanically. So what I mean by that is doing all the kind of conservative treatment may not be possible in very severe meibomian gland dysfunction. It may be that they need to have, they may have to have treatment. So it could be reducing the staph on the lids to try and calm it down if there's a little bit of, if there's a little bit of overgrowth there. It may be that you need to give them something more systemic. So we sometimes give doxycycline if their meibomian gland dysfunction is also related with rosacea as well. But doxycycline itself can upset the gut. So we've also got here down the left-hand side, you've got some bleph here, and you can so excess skin and also just general blepharitis. You've got atrophy of the glands. You've got some cicatricial, so scarring changes and thinning, and so you've got atrophy of the glands that is lost. So that's happened over time. It's a common picture in aging, and those eyes tend to get quite sore because they just haven't got, it's not a harmonious environment. And then sometimes you'll see this foaming, so that's enzymatic activity, and that enzyme activity is that those tears are being broken down, so they're kind of foaming up there. So some of the things that we can look for very readily is the tear breakup time, and I'm sure you all know how to do this. So essentially we put fluorescein on, and then we look at how long that takes for the negative staining patterns to appear. So that's the black staining. So you also see at the bottom, you can also see the tear film meniscus as well accumulating. So that's quite a good test. It's pretty subjective, but now if you're lucky, there are machines that will actually measure that for you. So I know that's available on, well, I know the MS39 has it. Some of the Pentacams have it now, tear breakup time, and actually quite a lot of them have this feature. Some of the machines that come with epithelial mapping, they can look at the tear breakup time now more accurately than us, but not everyone has access to those things. Tear meniscus height and the Schirmer's test. So the Schirmer's test is where you put these litmus papers in the corners of the eyes without anesthetic, and you look at that. That will help to just see if the patient is producing tears and a normal quantity. So I'd expect them to have over 10 millimeters in the 5 minutes that you do it for. So anything under 5, you might start thinking there's an aqueous deficiency there. But when you have true aqueous deficiency, it's really like 1 or 2 millimeters horizontal. Yeah, so it's on the Schirmer's test where the lines, the measure are, the horizontal line, that's how you'd measure it. So aqueous deficiency is kind of 5 millimeters or less when you do the Schirmer's, but anything less than that is an aqueous deficiency if you leave them in for 5 minutes without the anesthetic. So just clarifying that on the chat. This is the fluorescein clear, like clearing out. This is a clear out. So the time it takes for the fluorescein to clear, so you know how the system is working. So if you haven't got a lot of tears, you're going to get residual fluorescein sitting there and pooling in the eye. So you've got a delayed clear out of the fluorescein. It's not actually something that I look at, but sometimes you do look back at your patient eye after you've examined them and they've still got all that fluorescein sitting in the eye. And so you know that they have got they've got a poor turnover there, particularly in the really problematic ocular surfaces. So a tear lab or another checker can look at that osmolality. That is the most, now the paper said that's the most strongly correlating and reliable method of measuring ocular surface disease and dry eye. So with the tear lab, the calibrations vary, but usually anything over 275 microliters osmolality of concentration is where mild dry eye and then moderate over 300. So they will all be calibrated for a specific measuring scale, but that does seem to be the most accurate way of monitoring dry eye disease and picking up especially like mild dry eye disease. Some of the papers say that the fluorescein and the staining, they are better for more moderate to severe dry eye disease. So someone's saying about staining patterns, yes. With the staining patterns, we can grade. The Oxford scale is what I use because it's very quick. I'm sort of used to it. It is a bit subjective, but you can kind of go like grade 1 to 5, and essentially you're looking at that kind of general staining pattern, how many kind of little SPEs, like superficial epithelial erosions, are you seeing, and you can kind of quantify it so that it allows you to have something to look back at. But basically, if you're looking at 2 or more, they tend to be quite symptomatic, quite a significant dry eye there. And then the pattern is important too, because if you're not blinking fully, you might notice that they just have it very inferiorly. If you have it at the top, it might be something rarer like superior limbic keratoconjunctivitis, so SLK. It's quite unusual, and that's more of an autoimmune inflammatory picture, and that can be like they can sometimes be very red, just under the lid. That's not particularly normal. It is associated with thyroid eye disease as well, so that's something to like be aware of. So if you do see that, have a think about thyroid eye disease. And then you have the interpalpable, just general exposure. If in neurotrophic patients that don't blink because they just don't have the sensation there to blink, and that can actually be directly caused by something like diabetes or previous laser. In some patients, they have reduced neural responses, but more likely in herpetic diseases where you have changes to the neural sensation there, and you just might not blink, so you get staining in those patterns, and they might not even feel it, but it will cause blurred vision, and it also, that dry eye not only causes blurred vision, but it can predispose them to having a infection or an opportunistic infection. I'm gonna have a quick look at the chat a little bit. So all these autoimmune things, all those medications, it is worth having a chat through with those, because all of those will contribute to dry eye problems. As I said before, like what goes in our body does definitely. So we've got a few optometrists that are also suffering with the symptoms. Yeah, so yeah. It's just interesting reading the chat, how many people are experiencing having to try and manage their own dry eye as well. But there are vegan omega-3 supplements, and if you are vegan and you're experiencing dry eye, and if you have any autoimmune condition, I definitely think you need to optimize whatever you can with the plant protein, with your diet. So it is difficult. It is more difficult, but you pretty much have to have supplementation and anti-inflammatories there as well. There are some, it's not my field particularly, but there are people who have had great results improving these conditions as systemic, because they said that when you have like rheumatoid arthritis or autoimmune or adrenal conditions, hormonal conditions, those are systemic conditions, and because your ocular surface is part of that autoimmune and defense, they are affected too. So treating the systemic can help treat the eye. So back to sort of these signs. So basically, it's not, do look out for other signs that could be related. So I think we've actually, sometimes things can be quite subtle. So you can have like pterygia, pinguiculi, and those surface elevations. What they're doing is, if the tear themselves can't then coat and stay structurally organized over the surface. So when you have the pterygia themselves can be disruptive to the ocular surface, and then that can predispose those irritated symptoms and dry eye symptoms. Not everyone needs a pterygia treated, but that that can help in some patients, especially if they're getting inflammation, redness, discomfort. It's a reason to do it. Salzmann nodules, they're in the top right hand image there. So they're kind of these elevations, and they can be removed through surface treatments. So they can be removed manually, scraped away. So that it can be quite, and then they heal again. But they would need a considered course of anti-inflammatory antibiotics afterwards, which could then also re-trigger dry eye. So it's a process. But if you have the profile is not regular, then your tears are not going to be able to behave as well there. Lots of helpful conversation and chat for each other, so that's very good. Yeah, so at this stage, you should be able to differentiate between the evaporative dry eyes, those are the patients with the tear breakup time that's quick. The aqueous dry eye, they're the ones that are they've got the low volume from the Sjögren's. They're the ones that have got that low clearance, so that's staining, and they'll both have hyperosmolality because that's part of the dry eye condition. In the next photograph, you can see how it affects the measurements you take before surgery, but also how that would impact a patient's vision. So here you've got Placido rings, which are just those classic projection of concentric rings on the surface. And you can see that this would be seen as relatively reasonable. But after they blink, you can see it recoating the surface, and you can just see how those concentric rings lie up even better after the eye has blinked, and it just in real time, how when the eye dries out, how it would change and blur your image and make it maybe smeary, for example. And then in the right hand side image, you can just see how when you blink and it's just refreshed, how sharp and aligned those rings are, and how much better the clarity of vision would be. You can see from this shape of the eye that the patient would be a bit astigmatic actually, so it's a little bit egg-shaped. But if your tears are constantly breaking up, you're going to be living in that blurry image on the left-hand side longer than you'd like to. You can also measure your dry eye now through your epithelium. So your epithelium itself thins in dry eye. So because it's just the cells are getting damaged, and so you're getting this apoptosis, so you're getting this loss of cells. So you actually see that the epithelial mapping on the cornea, it is affected by severe dry eye. So you can see in the left-hand side, that is dry eye, because it's like these irregular patches. But the dark green, I think this is one of my patients actually. I think this is one of my patients who has a very severe ocular surface disease, something like Sjögren's, and you can just see how they have how it is so irregular and thinned out in the far right hand images, how irregular that is, and the darker colors are almost like where the epithelium is so thin, so that's like chronic damage. You can also see that with toxicity, like with glaucoma medication as well. So the last section really now is about breaking the cycle, things that you can do. We'll try and keep the bullet, sort of the attention up, because I can tell it's been quite a long session actually. So just take a quick 30 seconds. Is there anything people want to bring up? Alex, anything you want to bring up at this point?
Yeah, definitely. I just had a few questions that I noted down just nearer the top. One I wanted to ask, how would you start the conversation on menopause? Is it during the DQ5, or as you're going along?
How to start that conversation?
Yeah.
I would probably just say, like, you know, since your eye symptoms, if it's a new problem, like since your eye symptoms have started, have you had any other like systemic symptoms or anything? Do you think that you could be experiencing menopausal symptoms or perimenopause? And I'd be quite direct and open, and they might be like, no, I don't think so. Oh, I might think so. Patients often volunteer it as well. I have this incredible, and I must try and demonstrate and write her up, but I've got this patient who's got polycystic ovary syndrome, and she is convinced, and like there's nothing in the literature about this particularly, but we know that hormones impact it. But she volunteers the information. She didn't before, but she will, if you sit and ask. She eventually told me she has these things going on. I was like, okay, what else is happening? Well, you're like, all right, so there's quite a lot going on. And she's like, and then I've got this, I've got that. And they often then say to you, they bring up, go, do you think it could be the menopause? Do you think it would this? So if you give them the chance, or even say to them, you know, because obviously a lot of our colleagues are men as well. So I think it's important just to be quite direct and say, you know, do you have any other symptoms? Do you think you could be perimenopausal? Perimenopause sounds a bit nicer, doesn't it? And then if they're like, no, I'm in full menopause, no, it was years ago, then you know you won't upset anyone. But this patient with PCOS, so this is like cystic ovarian syndrome, she has dry eye, she is convinced, on the side of where she gets her cysts. Now, this is so unmedical, and we don't have, I mean, that whole gynecology obstetrics seems to be witchcraft to me anyway as a doctor. But this patient says that she gets them on the right, her inflammation happens on the right, same thing happened on the left. And when I saw her, she'd had a scan, and it correlated with the side of which it was inflamed. And when I saw her 6 months later, it was the other side. So I think patients will, if you give them the opportunity, they will volunteer this information. If you have a suspicion and you don't feel like they're forthcoming, then you can invite them to share. So I think we're quite lucky that we live in an era, yeah, technology aside, Donald Trump aside, I think we're quite lucky that we live in an era where there's a lot more openness about all of these subjects, and it feels like we are going to make tracks in terms of understanding that people are very individualized and nuanced. I don't think you should be afraid to bring those subjects up. Anything else there?
No, thank you for that. That was great. I'm not sure if this was touched on earlier, but how would you specifically treat Demodex?
So I think Ross actually,
Yeah, I did see that.
Demodex is an interesting one because it, as we get older, like I think it's nearly 100% of cataract patients of over the age of sort of 70 or 80 actually have some kind of some Demodex, and some Demodex is harmless and some is harmful. But there are Demodex seems to be killed quite well through scrubbing of the lid. So this is what Ross is saying, removing the crust, killing the eggs. But they also don't like the okra, they don't like the tea tree. So those kind of ingredients. So they'll talk later about the zocular, which is like an okra based, or tea tree wipes. They in particular, those two ingredients, they kill Demodex quite well because it doesn't like it, which is because it's like a little bug.
Horrible things, aren't they?
They look horrible when people photograph them and then, you know, zoom in on them. I can't say that I get too excited about Demodex, but then I suppose, yeah, you know, if you stare at them too long, they do look a bit horrible. But I believe that for a lot of people, Demodex is relatively harmless as well. Shall I carry on to trying to break the cycle?
Yeah.
Oh, look, we need them, but only when they're controlled. So it is about controlling the population. That's, again, it comes back to this concept of homeostasis, the balance. So breaking the cycle, or another way of going is to look at the balance. So how do you rebalance your system? So I kind of whizzed through because we talked a lot about it. If you want anything detailed, certainly you can screenshot this or look at this. It's all available for free. The TFOS Jews is always available for free. There's so many resources, but there are also hundreds of hours of reading involved. So this is kind of like your stepwise approach, and step 1 is going to be good for about 90% of those 90% of the MGD patients. So it's the majority of patients, step 1 is going to be fine, but it's all about engagement, education, and getting them to do those things and do them well. I've also put on here a kind of I think I just made a kind of cartoon version. So what we've got here is, there you go, teacher. We're on to teacher already. So we've got I see an increase of dry eye in AMD patients having intraocular injections also post-cataract. Well, that's any intraocular injection post-cataract. They are themselves, they are procedures, and they are going to change the environment. Cataract surgery is associated with transient dry eye, and if not managed in that spiral, can then spiral and then it become prolonged dry eye. So yeah, it's a very important one. Very rarely in your susceptible patient like Sjögren's, in a cataract Sjögren's patients, you can see melts. There was a patient that got post-cataract surgery. She had previous LASIK, and the combination of those two things and a bit of dry and being sort of an elderly sort of 80-year-old female, she actually got corneal melting from sort of the enzyme activities that caused like inflammation, caused melting, and then got infection, and very difficult to treat. And then they get the cornea change to shape and contour, and when it heals it becomes very difficult, and then you end up managing with rigid contact lenses again. So let's go back to this. So educate them. It's about that kind of changing what they're doing. So if they're doing something that's really obvious, like wearing loads of false eyelashes, and that's the main obvious thing, then you need to have a serious chat about that. If they're like on the screen all day, then you can get them like a timer they can repeat, or a sand timer for 10 minutes. They should turn it, blink, turn it, you know, something that's going to get them to engage, to make sure they remember to blink. Alex, when you're gaming at night, you know, you've got to remember to blink. You're 20, because, you know, our co-host Alex today is very young and male. So if you start getting dry eye, then we're in trouble. But we basically remembering to blink and modifying and taking breaks from screens and bright lights, and basically not doing doing a webinar every night like this. That would be very good for you. So then there's the warm compresses. So I'll show you a few pictures about those, but they're generally, like, I've got one here, but they're generally quite self-explanatory, and they're all packaged. They are. I think the thing is, the key here is to get the patient to actually do it. And sometimes I might say to them, think of it as like your spa routine, or think of it as like part of like your health package. Like, set aside time for, you know, you do this and look after yourself, because that's the only way you're going to get them to engage. If they don't see it as a chore, they see it as some kind of enjoyable wellness, because it can be very difficult to commit that kind of time. And then if you've got patients that are doing this stuff religiously, they're always doing eye warm bags and eye compresses, then sometimes they're the type A patients that are almost doing it too much, and they could almost be triggering inflammation. So that can be quite problematic. So lubrication is also, I do feel like lubricating the eyes with a preferred eye drop is helpful. And that's going to be the main treatment. So I think we've already talked about this: diet, modify your environment, educate the patient, eliminate all the offending medications and cosmetics where you can, lubricate, treat the MGD, think about lipid supplements. That's what we talked about as well. Lid hygiene, warm compresses. So step 1's the key for this, and then step 2 a little bit if you have, you know, if you have those sort of the availability to do that, and it straight away on there, non-preserved lubricants, tea tree oil if you expect Demodex, but also I believe ochre based, so the ocular products are non-inferior almost as well. Okay, and I'm going to run through that again, but more in detail. So the TFOS lifestyle report, which you can find the full report, will say modify these factors, and we've talked a lot about that. We talked about having breaks from the screen. We've talked about blinking. We've talked about all those factors that can contribute to it. So it might be things like contact lens breaks. It might be like optimizing diet, cutting back on caffeine, which could directly relate to dehydration itself, not using preservatives, thinking about what we put in our bodies as well as medication, thinking about what we put on our bodies. Omega-3 and vegan alternatives or vegetarian alternatives are available, but they would need to do that quite religiously to even have that impact. It's controversial whether it really helps, but I do think that some people it really helps. Someone mentioned a humidifier. So a humidifier actually can help with some patients, and they put it in their desk, so I've actually heard people do that as well. Just to be a little bit careful, because with the humidifiers, often people start putting in like aromatherapy oils and stuff, and that might be problematic again. So alcohol does dehydrate you. So alcohol also can contribute to dry eye in a kind of roundabout way as well. So they're all things to think about, sleep in particular, and just essentially kind of health, your general health. So if a patient walks in and you sit there and you listen to them and they tell you about all their factors, it is about kind of saying to them and going to them, what you have is a common condition. It's not really dangerous, and unfortunately it's often hard to cure. You'll have good times, you'll have challenging times, and we're here to support you to try and help build that stability and to try and help modify to make you more comfortable. So that's kind of what the aim is for people that have like quite persistent dry eye. So here you can see the tea tree and the ocular. Both these products can help with Demodex and blepharitis. It's not advisable to use too much tea tree if you because if you've got like a younger person with dry eye. Tea tree can be helpful sometimes, but I wouldn't say do it every night. You can overdo as well these things as well, but I do think so I'm saying it stings. You can overdo a good thing in the same way, like I said before, you can't compete with what nature gave you. So then it's got this hypochlorous eyelid spray here, so that's the one that's quite good at cleaning. So I also quite like Clean for makeup as well, or any kind of like eyelid wipe. So what's nice is the eye doctor and now Taya have both got plastic free wipes, so they biodegrade, which is good. And I think in this kind of culture of having lots of disposable stuff, it's not ideal. I also think, for a lot of patients, if they can get quite cheaply clean flannels, because not everyone will have the means to do all these things, but really hot clean flannel, hold it up to the lid margin as well, that could be good. And then they can just put them on like a standard wash and keep like 40s should be fine, and they can rewash them and reuse them, and then that can be an alternative that could be quite accessible for people. Especially one tip here is be really careful about doing hot compresses in the bath or cleaning your eyes in the bath. I remember being on call for the whole of most of South London as a registrar, and I hadn't got a phone call, and I decided to do like, oh, I'll have a bath whilst I'm waiting for a phone call, and I was like, oh, I'll get a clean flannel. I'll do my practice doing my lid gland massage, but I used the bath water. I didn't think, but I'd put Epsom salts in it. So I actually gave myself a mild chemical injury. And the next day I had my colleague had to give me some treatment because I'd actually managed to dry my eyes out. So you should just be really careful and sensible, because it's very possible to overdo it. Another colleague, patient, a friend of mine, I gave her advice to manage her chalazion. So she's doing hot compresses. She said, oh, they're such a relief. They're so good. She did it so hot that she actually burned the skin. Now, the good thing about these kind of eye bags that you can see, they don't overheat. So the reason why they're better is because the home treatments we do that are cheaper, they may inadvertently feel like they're like cheaper and cost effective, but with the bags, the contents don't tend to get too hot. You can reuse them a lot more. They've got properties that are antibacterial as well, so most of them have that. So sometimes it does feel like it's all very fancy, but sometimes these products are actually better. Now, one that's the Peep Club is the latest one I've seen. Sometimes it's not enough, doesn't get hot enough for some people, but I've had a few patients tell me that this has helped them. Younger patients tell me it helps them. So that's as a device, probably about 70 or 80 pounds, and they can just manually do it. So yeah, something to think about. So then you have your lubricating drops. So I am a big fan of for the preservative-free drops. I'm a fan of the Hilo range. I use them a lot. The Theolos range a lot, and also Carmelos as well, so Celibisc as well. And this is something that I have tried as an alternative. So this is the Manuka honey eye drop. So I you won't really get this in the NHS, but outside the NHS, I have actually tried the Manuka honey. It absolutely stings, and then you get relief quite quickly. So it's not for the faint-hearted. You need to really warn the patients, but there is actually, it's quite nice to know that it's a bit more of a natural product in some ways. It's quite nice to have a product that if you're not having just a lubricating drop, it gives you a bit more than a lubricating drop. But it is really important to warn your patients that it will sting, especially those that have already got a mild dry eye, and see how they go with that. But it's quite an interesting product. So you've also got lasers, so IPL lasers, and you've got other things. I use a lot of punctal plugs because a lot of the patients I see in surface clinic will have aqueous deficient dry eye. You can also use it in evaporative dry eye disease, but you need to make sure the lid margins are kind of relatively healthy before you do that. You don't want to be putting things in when they've got like, it's not really the first thing to go to. You want to try and clear the system first. So here you've got the Shield. So this again is a product that warms up. It's a gel that you use to clean, but it gives this like warming sensation. Something gives a bit of tingle. Something, again, patients probably quite like it. I know that Ross uses it quite a lot. And again, you need to inform the patients to feel a bit warm, and that's normal. So it's a different experience. And the Blephastine, so Blephastine mask, Blephastine goggles, I have patients that are dependent on them. So someone's saying, what are your thoughts on that? Someone's trying the peat wand. So the Blephastine goggles, I've got patients that have to use the goggles when they go out and about, and that really helps them. So all of these things will depend on the individual patient, but I think the key here is to use that stepwise approach. If they're not doing the basic things well, there's no point throwing a ton of money at stuff. There is a thought process whereby they may need a bit of help, like a treatment, like, perhaps an actual little treatment in-house before you then go back to step one. So they might need to have, like, sometimes patients find like the IPL laser or one of these sort of treatments on the lid margins can help reset them, in the same way that I might offer them like a low dose steroid. So that's why I'm going to mention steroids. That I'm quite a fan of resetting the surface if there is active inflammation and active staining. It may be impossible through sort of just supportive care and lubricants to get them back into out of that cycle, because if they're already in the inflammation, the cell damage phase, it can be a bit tricky. So sometimes steroids are going to help. So you've got Softacort is the most modern one. It's from hydrocortisone, which you'll see in treatments like eczema, for example, but it is also the weakest one. It has the lowest side effects, like the lowest chance of causing a pressure rise, but it's also the lightest in terms of its impact on the inflammation. So that's very good in mild ocular surface or managing patients longer term. It's actually licensed only for about 2 to 3 weeks, but we do often put it in longer term chronic eye patients who might need a little bit of anti-inflammatory longer term, like Sjögren's, for example, who we don't want to give them loads of steroids, because the accumulative impact of steroids, as glaucoma, cataract, earlier onset, that type of thing, which you don't want to do. And we don't want everyone to be dependent on steroids. FML is actually not preservative free, but we do still use it in a lot of corneal patients because it just seems to be quite well tolerated. It's a very well tolerated non-preservative free steroid. As you can see here, it does have a slightly higher rate of increased pressure, but it's still very much on the low side, so it's still a really good option. Then you have Pred 0.5% and Lotamax, but they tend to they start to have more of an impact on your pressure as you go up the ladder of steroids. This is now around the step 2 to step 3 when you start introducing cyclosporine is a good option, and we're now using it more and more. There'll be 2 new cyclosporine competitors in the next year. So Santen is the main producer of licensed cyclosporine that we have right now. It does sting. I tell the patients sometimes if they're doing an anti-inflammatory steroid course, I tell them to put the steroid in before the cyclosporin, just 5 minutes before, or a lubricant beforehand. Patients tend to get adapted to them and they get better with time. It can be a bit of a hurdle to get over. In really severe and really compromised surfaces, really problematic surfaces, we do also give off-licensed veterinary cyclosporin ointment as well, which is better tolerated. So there will be other cyclosporin coming out in the next year to 18 months. One will be coming from Teo and one from Sun Pharma. So we don't know how they're going to be, but they're coming out. You'll be aware of doxycycline. So doxycycline helps with regulation of it's a bit of an unusual drug. It's anti-malarial. It was developed originally, can be used for chest infections, treats rosacea on the cheeks, as well as regulating the tear film. But downsides, sun sensitivity, diarrhea, gastro upset, can wipe out the gut flora, not always the best and it's well tolerated. I see it better tolerated in men than women. That's just anecdotally. But doxycycline also, I've discovered only in the last few weeks, there is a modified release expensive version that's around 40 milligrams that you can get for the GP to prescribe potentially if they have access to it, that's better tolerated all around. Limacycline is another option, but the actual effect doesn't seem to be as good, but that's another tetracycline family. Remember, not for breastfeeding women, not for pregnant women, not for children. So in children, we have to treat them differently and they use erythromycin and things like that. And there's also products like azithromycin drops and Azita, for example. After that, you're looking at kind of step 3 and 4, which is kind of beyond the scope of this talk, but that's where we get blood serum eye drops, special therapeutic contact lenses, things like that. And then when we start looking at kind of regrafting the surface, if they have superior limbic keratitis or if they have like chemical injuries, things like that with dry eye, look at amnion and all these types of things. That's more complex ocular surface management. So remember, the ocular surface can be a life sentence. These patients can end up being very depressed, not taken seriously, and it can be quite, when they enter that spiral, that constant insult to the surface, that inflammatory response, it can really sensitize the surface, and it's that neurosensitization that in some patients can be really, really problematic. It's all about the homeostasis. It's all about rebalancing what you can at an ocular surface level, but also thinking about the whole thing environmentally and holistically. And I think that you'll get better outcomes for your dry eye patients. But the downside is it takes a lot of time. So I give you questions. I might just very quickly show you some of my interesting cases. This is obviously glaucoma. Just really quick point on glaucoma. Switch to preservative-free where you can. Yeah, prostaglandins, there's a kind of a question mark over those, whether or not they're particularly helpful. Switching to oral medication and really severe, at least in some cases, giving the ocular surface a chance to breathe. You might want to switch to oral acetazolamide temporarily, for example, to try and improve it. You can see here the epithelium being very thinned, and then restoring after surface treatment, it's a bit thicker. SLT is a laser type treatment which helps to reduce the dependency on surface medication, and in this day and age, this is something which we should really be looking to introduce earlier on, and there is plenty of evidence to do that. So sometimes people don't think about doing it, but it's really good, and that's what I would want for my relative. This is one of my regular patients who has a very severe ocular surface with very deep red vessels. So you can see her eyes here side by side, and you can see that she's got a very altered microbiome. So picks up infections. The left's got an ulcer, infections just hopping in the eye. This is a really severe dry eye. She doesn't produce tears. She has to put about 30 drops a day. This is because when she was in her early 20s, she got lymphoma, and she was basically told that she wouldn't survive. So then she had experimental stem cell treatment. So she has graft versus host disease. Now her body, the actual graft cells that were put into her, bone marrow transplant, her body now fights. So she now lives with the consequences of the disease. And sometimes she says to me that her eyes are so sore that she sometimes would have preferred to have died than to have been cured. But she's, that's something that she has to work through, but it's very, very challenging for patients like this. So that's graft versus host disease. This is a patient who had scarring and permanent changes from prolonged use of preserved glaucoma medication. There was nothing else except prolonged ocular surface glaucoma medication causing scarring, referred from the Midlands in the end. And you can see that fibrotic change at the bottom, really red eyes. The eyes start, you can see them after treatment. So stopping the preservative agents, giving them anti-inflammatories, you can see the surface becoming less and less red. He did really well in the end. But he already had some limbal stem cell changes and permanent scarring from the chronic disease, but he's done quite well. And this is the last special case. I've only showed it because it's quite rare, but along the lid margins, you can see there's something missing. There are no meibomian glands. There's something missing here. And then you can see this delicious wrinkling of the conjunctiva in the medial aspect here. You can see the whites all kind of like wrinkled and thick. Well, this is not normal architecture. This is called ectodermal dysplasia, and they don't have meibomian glands, and it's associated with all like other systemic things, particularly like less fingers and irregularity of the nail beds and stuff like that. And it's carried on the X chromosome. You can sometimes see partial in females, but it's mainly men. So yeah, we've got a couple of minutes for clarification and questions, but hopefully that was interesting and you learned something and took away hopefully some key messages about it.
Very informative, Laura. Thank you for that.
Hopefully everyone's excited about ocular surface as much as I am. There's still lots to learn. There's just too much to learn, isn't there, really? What would you advise a patient who has a lot of corneal damage, chronic, and is not motivated? So that one's for Helen. To be truthful, when you've got someone that's not motivated, and they've got chronic ocular surface damage, you probably do need to get them on steroid to break the inflammatory cycle at that point. And if they're uncomfortable, then and they're not motivated, that's a bit tricky. But certainly you may need to, if it's beyond your scope, I feel like medical anti-inflammatory is probably quite an important way to start. Yeah, I mean, dry eye, you can practice it in a very linear way, or you can you can sort of think about it in this more holistic way. What's the doctor's like? I'm the same with chloroquine. Yeah. No, I think doxycycline works quite differently, but people used to take it. It's also used to treat Lyme disease as well, and it's also used to treat bacterial infections in COPD. It's a really interesting drug, tetracycline, but it doesn't have. I think when you say chloroquine, Gillian, you're referring to the risk of kind of the maculopathy and change in the retina, and it doesn't have those side effects I'm aware of. Doxycycline, the one side effect I've seen of it, which when it was used to treat acne in a patient, I had a young woman present with headaches and she had optic disc swelling, so super rare, but she had tetracycline induced optic disc swelling, so that's very rare, but that's a side effect of doxycycline. Peep Club, I want to try the Peep Club just because I think I quite like the design of the wand, to be honest. Humidifiers, yeah,
I did have. Oh, sorry.
You go for it. One more question, then we can.
I just had one a bit above there, and I'm not sure. I don't think it was answered. When it comes to recommended lid hygiene in an NHS setting, you know, in preparation for, say, a cataract surgery, what can we sort of recommend in that NHS setting if commercial wipes aren't available?
Okay.
Sorry, that was it.
So I think similarly to saying with the flannel, so if you heat up a hot sterilized for these patients, so boil a kettle, clean bowl, hot boiling water in there, flannel in there, wait till it cools down, and then you should have sort of sterilized water until it's not too hot, and then they have to be quite careful, but they can use a very clean flannel and they can hold it and then they can do the hot compresses and massage. That can be helpful. I have recommended eye-friendly facial washes for patients. You have to be a little bit careful about not getting too much chemical in the eye, but like foaming cleansers which are neutral. I think there are a few brands. I haven't seen them for a while, but they're eye friendly. We don't want to go down the baby shampoo route too much anymore, although that could be, you can actually do it to scrub off the makeup. It's just that we lent on that a bit too much, and then that can actually wipe out some of the flora that we want as well. So it's about like not overdoing it too much, really. But yeah, you can get rid of quite a lot of debris with cotton buds. So cleaning them with sort of a clean flannel, then cotton buds, and then cleaning the lashes along. Cotton buds are quite helpful for that as well. I don't recommend sodium bicarbonate anymore. I think it's really easy to go give it to have too much and then get like an irritated or sore eye. But yeah, if there was a trend to do that for quite a long time. Hopefully that's helpful-ish. I'll stop sharing my screen.
Yeah, I'm back on. Yeah, so that was really good, Laura. Thank you, you know, for the explanation. Oh, we got
I think alcohol can cause a problem. I think so. Actually, so flannels are the cheapest option because you can reuse them, but I actually do prefer cotton pads. So I personally use cotton pads, but then they do need to buy them and then throw them away. But you can then wipe and something else I also say to patients is when they're cleaning their eyes or eyelashes, if they wipe in the direction that you want the lashes to grow, because if you scrub, then you can actually get the lashes can start growing different directions and you get like trichiasis. So something that I've noticed. So, you should clean and move the lashes up. That's a tip. But I think we've come to a close.
Yeah, I think can we just put that QR code back on for everyone? I don't know. I think obviously everyone who's still on at the moment, you will get an email with instructions on how to claim, but if
Wasn't there one right at the end? I thought
there
it was at
should
the end.
be. If not, then it was nearer the start, wasn't it?
Right at the start, but it must be at the end as well. There we are.
Amazing. Cool. So yeah, any further questions? I've tried to note down each one. I don't think I've missed any, but if I have, you can
I think we
always
got into quite
email.
deep conversations, to be honest. And I can see on the
Yeah.
chat it made people start thinking about things in a different way. I mean, most of the time it is really about that step one. It is about step one,
Yeah,
isn't it,
definitely.
really?
No.
Simple things well, but like I said, it is about engagement of the patients. And I mean, who's a good patient? It's rare. You have to think, look at yourself. Would you be a good patient? Like I always think like, how would I manage this and fit this all in? And that's why I try and strip it back to sometimes it's a matter of just listening to them and saying, okay, just do your best, pick one thing you can do. Yeah. And then they can build on it in time. It's very hard to knock these things out overnight.
Yeah, totally.
Education, that's correct. Educate if you can. Preach without preaching. It's tricky. I mean, I should probably go and do this now after this session. Go and do my eye mask. But the trace is on, guys. So it's 9 o'clock. I'm sure I see a lot of you again. Say hi when you see me. And let me know, Alex, when you want me to.
Yeah, I think that's it. There's questions I've slowed down.
An
Oh,
over the
what
counter.
would
Yeah,
you
I mean,
recommend?
alcohol. the less like the more considered we are with what we do with our eye health, the better, really. Clean flannel soaked in hot water. A person can tolerate the wipe, closed lids, but slight pressure on the lid. Yeah, yeah. So that's I often find, like, for elderly patients, they, because it's like bigger, the flannel, clean hot flannel, and they just sort of hold it and clean, and yeah. Cotton pads I prefer. Would you recommend an over-the-counter eye wash? Over the so the last question, over-the-counter eye wash. I used to, look, I've actually rubbed my eye now, look. I used to recommend, like, as I said, eye-friendly, like non-toxic, like to get them to scrub their makeup off as being better than eye makeup remover. But if I'm honest, I do actually think these types of wipes are like these wipes, they are like the best ones to really get down to the base and just, not overdo the makeup.
Okay. Yes, thank you, Laura. That was amazing. You've taught me quite a bit, actually. And yeah, it seems that everyone is very very happy with it. You can see all them comments there. Some great discussions as well, in between. See you later, guys. Bye,
Bye. Bye,
Laura.
everyone. Nice to see you.